Well, thank you for being here. And I really appreciate that you are interested in the endometrial factor. So what I'm going to do is just for the next 15 or 20 minutes, I'm going with you through this endometrial factor to fully understand that. First, I would like to disclose, this is not going. First, I would like to disclose that I am just working in my own foundation, and we are founding specific companies devoted to specific topics that come from our research, in addition to being the external scientific advisor of big pharma companies, including Igenomix. So what I would like to cover in the next 10 minutes is basically to discuss about the concept of the endometrial factor, what precision medicine is, and to understand the two main topics within the endometrial factor, which has been basically the microbiome and also endometrial receptivity, to cover two basic issues that we have been going from the bench to the bedside for the benefit of patients. And this is what I would like to really inform you about. Regarding this, I think that this is something which is quite obvious, that nowadays we are transitioning from generalized medicine that is based on percentage population averages to what is important, which is precision medicine or personalized medicine, which is based in your particular patient. We know for a long time that this is even more important to know the patient than the disease, because everybody reacts in a different way. So that's why precision medicine is being used for a long time now in oncology and make the difference between life and death. And this is the whole dream will be also to use it for reproductive medicine in order to improve our results. And somehow it is being used nowadays for stimulation, ovarian stimulation. We do not stimulate all patients in the same way, obviously. We do not treat our patients the same, but when the time comes, we treat all of them in order to transfer the embryos and in order how to treat the embryo. So this is just to gain knowledge and be able also to move this. And the place that we work is in the preconceptional space, because this is where the action is. Pregnancy starts here. If we take care of all of these factors, we will be better off, because once pregnancy is established, as a gynecologist, the only thing that we do is to be sure that the embryo grows correctly. If we find an abnormality, nothing can be done. We will do surgery later on, or the pregnancy should be ended. Or if we have a preeclampsia, we will just stop the pregnancy as soon as possible. But everything happens within this space. And this is what we have been working with, acknowledging the relevance of the embryo, of course. But in addition to the embryo, the mother has many things to say. And the first thing is the fact that once the embryo enters in the uterine cavity, day 4 or 5, what he's going to visualize is the endometrial microbiome, because there is a microbiome that exists in the luminal part of the uterus, and this is important to consider, and I will show you why. Then the embryo and the mother will interact and will cross-communicate. And in fact, what the molecule that the mother passed to the embryo, they will be very important, even modifying the transcriptomics of the embryo and changing things for the lifetime for it. And then after that comes the initial attachment, which is when the embryo will adhere to the mother, and this is the starting point of pregnancy, and later on the embryo will invade, and decidualization is key in order to allow the invasion process that will be shallow, and then we'll have preeclampsia, will be proper, everything will go okay. If it is excessive, we will end up having a percretism or acretism. And once the patient delivers, we will have an issue because the placenta will not detach. So all of this happens in this moment, and that's why we have devoted our work on that. So let's discuss about the microbiome. So we are not only surrounded by microbes, but we are living, microbes, they are living on us and helping us to do our functions. And we know that we have 10 times more bacteria than cells. And if you weigh about 70, 75 kilograms, 1 kilogram of your body weight will be because of the bugs that they are living on you, mainly in the digestive tract and in the skin. So this is something that we know. The issue is that until now, bacteria can only be cultured, and only 20 to 60% of them, they will be cultured. So that's why until very recently that we do not have next generation sequencing, all of our knowledge about bacteria was biased because of technical situation. Now with the advent of next generation sequencing is when we have been able to ask ourselves whether an endometrial microbiota exists. We know that the vaginal microbiota is not about that. We know that 10% of the microbes, they are in the urogenital tract, but this was a big question mark. What we knew about that is that this is the next generation sequencing works. All of these works they were doing by culturing the tip of the catheter when they introduced the embryo. And what they learned from all of this was that basically, if they found those pathogens, this is going slow. Should I point to? Should I point to here? Yeah, sorry. So if you have, if those bacteria grow, basically we are getting a decreased implantation rate and increased miscarriage rate. This is what it was known in the era pre-next generation sequencing. Then we worked since more than 10 years ago, and Inma Moreno was the main investigator of that. We start trying to understand using NGS basically to analyze the bacterial DNA, and if we are able to analyze this is the 16S ribosomal RNA, those hypervariable regions teach us what is the identity of the bacteria. So by doing this, we learn that indeed there is a microbiome that is present in the uterus, which is different from the one that is present in the vagina. Is close, but 20% of cases they are different. And well, I will pass this like that. And the thing is, in this very first pilot study, what INMA learned is that when you have what we call good bacteria, which is lactobacillus, the blue, to more than a certain percentage, 90%, we call lactobacillus dominant microbiome, results, as you can see, they were really good. However, the same set of patients with non-lactobacillus dominant microbiome, pregnancy went from 70 to 33%, miscarriage from 16 to 60%, live birth goes down. So this was an initial observation from a pilot study that teaches, okay, it will be interesting to see the microbiological angle of the endometrial microbiome there. And this is what we did. So there is a number of published evidence since our work of 16, not only from us, but also from the group of Richard Scott, founding the existence of this endometrial microbiome. And even it was this paper coming in Nature Communication in 2017 that they found that there is not only an endometrial microbiome, but a microbiota continuum throughout the reproductive tract with different type of pathogens. You see the vagina, and then the uterus, the tubes, and even the peritoneum. So there is an ecosystem there that we have to know in order to learn what is normal and what is dysbiotic. That's the point of this. And we were fortunate, and we identified for the first time ever the first glimpse of the endometrial microbiome in a normal human pregnancy at the 4th week of pregnancy. This was a patient, this was my patient that I was fortunate to see. This was a young patient with very good embryos, euploid embryos. I transferred the embryos once. She became pregnant, but she got a spontaneous abortion. And this is the microbiome here in your right hand of the microbiome once the patient miscarried. Because of the miscarriage, we did a curettage, we gave them antibiotics, and she came back in September. She was 1 day delay of her cycle. So I just took endometrial fluid without knowing that she was pregnant, and I find out this 7 days later. So you have there what is in the endometrial microbiome of a normal human pregnancy with the embryo there. So we know that this is the proof of concept that this should be a good microbiome. As you see, everything is lactobacillus, mainly lactobacillus inners. So let me show you. This is the video that you can find in American Journal. No. Yeah.
Around 9% of the bacteria in the human body can be found in the female reproductive system, where bacteria may facilitate or hamper human conception. Using 16S rRNA sequencing and functional metagenomics, we described the human endometrial microbiota in a patient who had an 8-week spontaneous clinical miscarriage with euploid embryos, and, for the first time, during a successful pregnancy in which the endometrial fluid was sampled at 4 weeks of gestation. Lactobacillus inners was the most prevalent microbe found in the endometrium during early pregnancy, associating its presence with defense mechanisms and basal functions. The microbial profile prior to the spontaneous abortion had higher bacterial diversity and lower lactobacillus abundance, showing an unstable functional pattern characterized by transposisis and insertion elements. We found taxonomic and functional differences between the microbiota found in the endometrial fluid collected during an early successful pregnancy and prior to a spontaneous abortion in the same patient. Further investigation of the microbial community in the female reproductive tract. Around 9.
And we continue with further investigations, and this paper was published January this year. By which we just did a multi-center observational study with about 300 patients in 8 different centers worldwide. And what we learned here, this is the flow chart of the study. This was, again, observational. We did not intervene. We just obtained the endometrium and the endometrial fluid, and then we follow the patient and to find out whether she had good outcome, which is live birth, or she has a bad reproductive outcome, which is clinical miscarriage or no pregnancy. So what we learned, you can find the paper. So this is the message. What we found is that when you have a poor outcome, this is the signature of the bacteria that they are increased, related to no pregnancy or just clinical miscarriage. And you can find this in endometrial fluid and so in the endometrial biopsy. So this is the signature of pathogens related with poor outcome when you analyze this. And on the other way around, this is the signature of the good guys that they are increased in live birth compared to bad outcome. So as you can see, lactobacillus was almost nothing, below 95% as well, both in endometrial fluid and endometrial biopsy. So all of this collecting the idea that the endometrial microbiome exists and there is a signature which is associated with reproductive outcome. And now studies, interventional studies, they are coming. I just read one from Japan that they are just already treating the patient and then transferring the embryo afterwards to see at what extent we can improve the results. So in summary, from this part, the endometrial factor, considering this microbiological angle, the point that I want to make here is there is a pathogenic profile associated with reproductive failure based on this microbiome. Lactobacillus is consistently enriched always in endometrial fluid and endometrial biopsy. Both microbiota, they are not equal, endometrial fluid and endometrial biopsy, but they are very consistent because there are some pathogens that they are extracellular, this is the main difference. And of course, our point is that the endometrial microbiota should be considered as a possible emerging cause of implantation failure. And this is another angle for us to learn about that and to improve the quality of care of our patients. And the next step is endometrial receptivity, which is basically the point that I want to make now, and it's based on the ability of the embryo to adhere to the endometrial epithelium. And this is possible because the endometrial epithelium changes. It is transformed. It's what we call the plasma membrane transformation. If this doesn't happen, pregnancy will not occur. I say this many times, a human embryo can adhere to any surface, can adhere to the peritoneum, to the tube, you have an ectopic pregnancy, to the plastic, you have a transfer catheter that you have to try again, but will never adhere in a non-receptive endometrium. And most of the time, in your menstrual cycle, you are non-receptive. There is only a window of opportunity that this plasma membrane will occur, and now an embryo, which is an immunologically and genetically different organ from the mother, will be able to attach and to make it happen. And in fact, this is the reason for the continuation of the species. So we always have tried to understand how receptivity occurs from anatomical medicine to molecular medicine. As you know, anatomical medicine failed for many times. We have the Noyes criteria. And then from more than 20 years ago, we and other groups, we tried to use the new Google glasses of the transcriptomics to understand how can we identify objectively when the window of implantation will be ready by analyzing the transcriptome of the endometrium at that moment. And at that time, we used the whole tissue, the whole endometrium. And by doing so, we identify a transcriptomic signature that we later on verify using single-cell RNA-seq, and we published this in Nature Medicine. By doing the same, but now cell to cell, we analyzed those cells, and we were able to identify that when we are now separating the different compartments, this is what happens in the epithelium. This is what happened exactly where the implantation, the addition occurs. So as you can see, with your bare eyes, there is a difference in color here. There is a step, and basically means that some genes are turned on and others are turned off immediately. And this is the reason why the window of implantation opens, and this set of genes coincides with the genes that we have in the ERA. And that's why the whole point to say, okay, now the window is open. This is the personalized window of implantation of your patient. This is completely different from the stroma. The stromal compartment, as you see, you don't have this abrupt change. You rather have a more discrete changes that go through the decidualization. And decidualization starts before the window of implantation opens. So we learn all of this from the basic part. But at the end of the day, the clinical lessons was there is a window of receptivity. And this window of receptivity is not for everybody, is not the same. The window is about 40 hours, but some patients need more time or less time for the progesterone to produce this. The window of implantation is directly related to the activation of the progesterone receptor. And progesterone receptors, they are different. You may have polymorphism, you may have different phenotypes of the progesterone receptor, and that's why the reason all the patients, they do not have the window of implantation at the same time. The majority, 70%, will be after 5 days, 120 hours of progesterone exposure. The majority, 70%. But in 30% of cases, patients will need more days, more exposure to progesterone or less exposure to progesterone. And this is the concept of individualizing the window of implantation and knowing when a patient will be ready to be transferred. And according to that, we create the concept of personalized embryo transfer, initially for our most difficult patients, those that fail everything. And the concept is very simple. Instead of transferring the embryo only when the embryo was ready, let's do it when the embryo is ready, but also the personalized window of implantation of the patient is there. And according to that, then we move forward, and this was our first paper showing this in patients with repeated implantation failure. And this has been the very last paper, also in repeated implantation failure from an independent group, again validating that those using ERA improve clinical pregnancy and implantation rates. But the best that I can offer you about the data that has been generated in the last 6 years or so, you can find in this paper, table 1, you have all the papers that they have been working on both recurrent implantation failure and good prognosis using clinically the ERA and see what happens. And also this is a meta-analysis published in April this year, taking into consideration, again, these two main outcomes that I would like to revise with you. So this is the meta-analysis analyzing all the published data at that time, and they divided in patients with poor prognosis, those with recurrent implantation failure. Remember, recurrent implantation failure means patients that they have low chance of pregnancy. Typically, we identify them because they have failed 3 times, at least 3 times, good embryo transfer, and this is what we call poor implantation rate, and then patients with good prognosis. So for those with recurrent implantation failure, all the data that are there, the authors indicated that personalized embryo transfer guided by ERA significantly increases the chances of pregnancy for non-receptive patients with recurrent implantation failure of endometrial origin. In a way, the point is if you use ERA, the clinical outcome will be similar to those with normal patients. So this is something that we were just trying to find out. However, for the good prognosis patients, the data that are there, you have live birth rate goes from 39% to 53% using ERA, but this is not statistically significant. So even if you have the difference, they say that for good prognosis patient, it's not clear at what extent we will help us to improve. But the thing is, for good prognosis, there are 2 randomized clinical studies done. One that is published, it was by our group, in which we found that per intention to treat, we found no differences because it was a high dropout of 50% of the patients for mechanical reasons. But when we analyzed per protocol, we find out that there was an increase in implantation rate, pregnancy rate, cumulative pregnancy rate, and cumulative live birth rate compared to frozen and fresh. For live birth, there was an increase of 13 points and 10 points versus frozen and fresh. However, this study was powered to find out 15% differences, so it was not significant. And the other study that has been sponsored by us, has been done by Shady Grove, is not published yet. They use embryos, PGTA analyzed embryos, and they show no clear results, no clear differences, but it's not published yet. But it was presented last year as an abstract in this meeting. Now, recently it comes this retrospective study from the center that I used to work in, and it was interesting for me to see that in the same center, with the same patient population, the same topic, 2 studies give us different results. And when we just saw what happens there, you can see this is the retrospective study left, and this is our randomized clinical trial, and those are the same patients in the same center. So, but the interesting thing was that when we learned the paper, the data in the retrospective study, they did not include those patients that it was involved in the randomized clinical trial with good results. And seeing the numbers of patients that they have been considering, 88, and the one that involved in our RCT, well, we don't know why they were excluded, but certainly this is a bias in addition to what a retrospective study is. So this is just to show you pros and cons and what has been published about that. The thing here is that in this meta-analysis, what we can see is that in recurrent implantation failure patients with these numbers, this is the pregnancy live birth rate that has been reported. And they are really, the conclusion is that they're really helping these patients. And for patients with good prognosis, as you see, this is the number, 39% with no ERA, 53% with ERA. But even so, as you can see, the percentage that we obtain in patients with implantation failure with ERA, they are similar to patients with good prognosis without ERA. So finally, I just want to show you this because it's something that we have always seen. Once you create something, there is always a panacea paradise. Later on comes the harmful hell that Dr. No is saying that's terrible. And finally, we will have a consolidation period, and the reality should come from the consolidation of studies and the proper analysis. And it happens for each test, also happens for PGTA, and of course, ERA is no exception. And with that, I think that I just passed my time, and I just want to thank you. We are continue working on that to make that the pathologies of the affecting the uterus will no longer be an impossible barrier, and we are doing this in a foundation with the basic research team that are working on that. Well, thank you very much. If you have any questions, I will be happy.